Good morning, everyone, and welcome to my YouTube channel, Pain Free Partha. Today, I'm going to talk about calcium gluconate injection only. I'm not going to talk about calcium and anesthesia concerns. So, calcium gluconate is a calcium salt of gluconic acid. So, calcium salt of gluconic acid, and gluconic acid is an oxidation product of glucose. See, there is a 93 milligram of elemental iron in 10 ml of 10% calcium gluconate. What is 10%? 100 milligram per ml. What is 2%? 20 milligram per ml. What is 0.1%? 1 milligram per ml. Then what is 0.51? 2% lignocaine means 20 milligram per ml. 0.5% bupivacaine means 5 milligram per ml. Now 10 ml of 10% will contain 1 gram. So, but if the elemental calcium has to be considered, 93 instead of 93, we have calcium chloride salt, which is 272, almost 3 times. But usually our calcium gluconate, which is less only 93, is preferred over calcium chloride, which is 272, because whenever it is extravasated, it does not cause tissue necrosis. But calcium chloride causes tissue necrosis. That is why calcium gluconate is preferred. There is something called calcium borogluconate, which is used in veterinary practice. What are the indications of IV calcium, or sometimes other routes also? Hypocalcemia, cardiac arrest, cardiotoxicity due to hyperkalemia or hypermagnesemia. These are the three main things. Hypocalcemia, a cardiac arrest due to hyperkalemia or hypermagnesemia. It is not cardiac arrest. It is cardiac arrest due to hyperkalemia and hypermagnesemia. They are using for beta blocker toxicity, calcium channel blocker toxicity, magnesium toxicity, and hydrofluoric acid burns. Black spider envenomation, hypoparathyroidism, renal failure, acute pancreatitis, sometimes eclampsia. These are all the off-label indications. Beta blocker toxicity, calcium channel blocker toxicity, magnesium toxicity, hypoparathyroidism, renal failure, acute pancreatitis. What is important? Hypocalcemia, cardiac arrest due to hyperkalemia or hypermagnesemia. When you see hypocalcemia, it occurs in almost, see here, 15 to 88% of hospitalized patients. Our calcium mainly resides in the bone. In that 1%, 40% is circulating is bound to protein and 50% is physiologically active. Other salts are there in 10%. Clinical manifestation of hypocalcemia depends upon two things. Number one, severity, how much it is decreased. Number two, how fast it decreases. These are all the two things when you say hypocalcemia symptoms. What is the normal range? If you say it is between 4.6 to 5.25 in terms of milligram per deciliter, what is this? Ionized calcium. Normal calcium is 8.5 to 10.5. So if you say it is 5 and 9, 5 is ionized calcium, from 9 is normal calcium. This is slightly okay. The emergency treatment of hypocalcemia focuses on reversing symptoms. Very important. If you give calcium, you should take ECG and not take again serum calcium level. So it is reversing symptoms rather than correcting serum calcium levels. You need to then repeat even 4 to 6 hours after calcium treatment. The patient should undergo an assessment of hypomagnesemia because low magnesium can cause decreased calcium levels. Severe symptomatic hypocalcemia, seizure, laryngospasm, tetany. So when the patient is having severe symptomatic hypocalcemia, laryngospasm, you should give 10 ml of 10% over a period of 20 ml over a period of 10 to 20 minutes, 15 minutes, 10 minutes. Finish it off. That means 1 ml per 1 minute. Finish it off within 10 minutes. Maybe up to 20 ml. Half a minute, 1 ml. Finish. When there is severe symptomatic hypocalcemia, patient is in laryngospasm. can give calcium chloride in central lines. The bolus can be repeated for persistent symptoms until symptomatic resolution. Again, we can repeat because we don't know what is the cause of hypocalcemia. Sometimes we know this cause of hypocalcemia may be persistent for 4 to 6 hours or 8 to 12 hours. So we may need to repeat that dose and persistent symptoms. And after this, follow the symptoms of moderate hypocalcemia. Should not receive bicarbonate during calcium administration. When there is a moderate hypocalcemia but without seizure or tetany, yes, we can give the same dose over a period of 4 to 5 hours. There is no much of emergency in this. Mild hypoglycemia, we can give 2 grams of calcium gluconate over again 3 to 4 hours, and we can give oral calcium also. This is what is the management of hypocalcemia. If it is severe symptomatic, give 20 ml in 10 to 12 minutes. For example, you should give 1 ml in 30 seconds, half a minute. If it is not that much, you can give 1 to 2 grams over a period of 2 to 3 hours. If it is very mild, give that and start giving calcium. All patients, symptomatic treatment is important rather than repeating calcium levels. You need to sustain by giving another 10 to 20 ml over a period of 4 to 6 hours to maintain asymptomatic patients. In hyperkalemia, calcium increases the threshold potential, thus restoring the normal gradient. Onset of action is within 5 minutes and duration is 30 to 60 minutes. Think calcium will not cause decrease in potassium, but ECG abnormalities will change. This is what I'm telling. Symptom treatment, ECG treatment is important rather than checking for serum calcium levels. Cardiac toxicity due to hypermagnesemia. Yes, again, you see here, the patient is toxic, hyper severe, 10% solution, another 10 to 15 ml over a period of 2 to 5 minutes. That should be given. These are all about IV. Now we go to hydrofluoric acid burns. Yes, calcium gluconate can be used as a 2.5% gel for hydrofluoric acid burns. We can also use with hydroxy with glycerol calcium gluconate. Gel is applied and massaged on the vein area for 30 to 60 minutes. Persistent pain in 5% can be injected subcutaneously. See here, people think only IV. Cell is there, subcutaneously there, 0.5 centimeters away from the burning border. Now we will go to, now we have clear indications. Hypocalcemia, cardiac arrest due to hyperkalemia and hypermagnesemia. These we have treated now. Now we go to off-label indications like beta blocker and calcium channel blocker toxicity. Yes, it is a viable option. A 10% calcium gluconate should be administered over a period of 5 to 10 minutes. Can be repeated. Continuous infusion of 0.6 ml per kg per hour. Yes, can be done. Calcium channel blocker toxicity. Again, 0.6 ml per kg or 0.5 ml per kg, 25 ml. Approximately, you can give over a period of 10 to 15 minutes and then 3 to 4 times by continuous infusion. The ionized calcium level can be monitored. And we should achieve 2 times the normal. What is the normal ionized calcium? Around 5. What is the normal serum calcium? Around 9. So, achieving the calcium level ionized, 2 times the normal is needed for calcium channel blocker toxicity. There's a novel preventive therapy of ovarian hyperstimulation syndrome. This has been there. Prophylactic infusion of calcium gluconate to avoid, if you do a total thyroidectomy, I mean, calcium like, not needed. Massive transfusions and severe hypocalcemia. There are supplemental guidelines. Routine administration of intravenous calcium during neonatal extinct transfusion, yes. Now we will go to adverse effects. Syncope, bradycardia, paresthesia. Calcium chloride, severe tissue necrosis. Calcium gluconate, less. Phyronouridase antidote an option. cold dye compressors, extremity elevation. All these things has to be done if it is extravasated. What are the contraindications? Again, same hypercalcemia we don't give. Calcium hypersensitivity we don't give. What is important is sarcoidosis. This disease itself causes abnormal calcium metabolism, leading to hypercalcemia and calciuria. So if you give calcium, there is a problem. Intravenous calcium should not be given to patients with hyperphosphatemia and renal failure. Yes, if it is not hyperphosphatemia and renal failure, the renal failure, hypocalcemia, no hyperphosphatemia goes into fits, yes. But if it is hyperphosphatemia, beware. Significant symptoms is there, go ahead, because it can cause calcium phosphate and calcifications. So what is it? Calcium gluconate is important. Calcium gluconic acid. Gluconic acid is derived from glucose. Calcium gluconate 10 ml, 10%. What do you mean by 10%? 100 milligram per ml. So 10 ml contains 1 gram. Calcium chloride, yes, 273 milligrams of elemental calcium. Here it is only 90 approximately. 3 times. But we don't use calcium chloride much because we are worried about extravasation. If we are not worried about extravasation, we have a central line and we know this is hypocalcemia in bypass surgery or cardiac surgery. Yes, we can give calcium chloride there because the fast action, the fast replenishment of ionized calcium is there in these cases. So it is beneficial. Indications: hypocalcemia, cardiac arrest due to hyperkalemia and hypermagnesemia. These are the main things. The other things are beta blocker toxicity, calcium channel blocker toxicity, hydrofluoric acids, pancreatitis, renal failure. Be cautious about hyperphosphatemia. Yes, thank you very much. Go to my YouTube channel, Pain Free Partha. Listen, and thank you very much for all the listeners.